welcome to IS Network webinar. My name is Charlotte Thompson, and this is my first time as one of the presenters, so bear with me. Your has been muted, but if you would like to chat, you can use the WebEx to communicate. It is in the drop box. If you select all page participants from the drop-down, you can type in questions for discussion. In technical issues only, please chat to the host. So let's do a check-in. Who's on the line? Please type your name and organization you represent in the chat box. Check all participants, please. People, how many people are you and what location you're at, please? So that's to type. So thank you, everybody, and welcome to the webinar. This is your first time finding this network. It's been developed to share information about provisions, strategies, and tools related to improvement facilitation and quality improvement in care. Shared should be operationalized through the lens of your PCN. Ensure that the strategies and tools you wish to use align with your PCN tackle class. The topic is around Schedule B, a deeper dive into TNA and access. We're going to talk about TNA that's available, and I can turn it over to Angie Johnson with AMA.
Hi, can people hear me? Can I get a few texts in the chat box to let me know that I'm audible? Perfect. So you can advance the slide, please, Leanne. Today we're chatting about third next available, and just to make sure we're all kind of anchored to what we're talking about, TNA, or third next available, is a measure that's taken very easily at the clinic level. And basically it just a number of calendar days between the day a patient makes a request for an appointment with a physician and the third open appointment in the schedule. And that's for a physical appointment, any routine appointment, return visit exam, however the clinic happens to term that. But it's essentially the third next available appointment. And just for reference, this is a definition that's used in the Alberta Health Toolkit that was distributed back in May 2016. That indicator was released. First indicator, in fact. And what PCNs are required to report on are the number of physicians collecting third next available as a percentage of their total number of physicians. So that's to give us an anchor. Slide. But why is this measure important? Continuity seems to be the word that everyone has on their top of mind and certainly is the buzz. And we know that when patients have timely access, that their relational continuity can be at its best. It has the best chance of being strong. And so we know that continuity leads to better patient health outcomes, decreased costs of the healthcare services and system, and high patient and provider satisfaction. And this is borne out in the data. In case people wish to go deeper into that, it's very easy for us to provide you with that will give you more detailed information about that. But I'm guessing many of you have seen those already. Hopefully that makes good sense to people, that if our physicians and our nurse practitioners have time slots available, obviously continuity is going to be maximized. Go slide. How to count it, and what we teach to the clinic level, and ideally this is what PCN are able to reinforce at the front line, that it's counted at the same time and the same day of the week. So example is typically Tuesdays at 10 a.m. or Wednesdays at 9 a.m., that it's done the same way every week. We count carve-outs. Essentially a carve-out is old time in the calendar that the physician or nurse practitioner has that only certain patients can book into, certain criteria. So typically that will be things like an urgent appointment, that will be like an annual physical, that might be women's health. The idea there is that you skip over those. Those are not counted as available or open time slots because the average patient cannot book into those time slots. We also recommend that the data is recorded. The number of days is data, and that's recorded somewhere so that you can track progress over time. These are for improvement, not judgment. I don't think I need to go into great detail here with the folks that are on this call, but certainly it's very easy for practitioners, our physicians, our nurse practitioners to feel scrutinized depending on the size of their TNA. And so that's not the point here. The point is to be able to see your data and to look at that over time to see if what you're trying to do to improve access is actually improving. Count it from the patient's perspective. So that means that we actually include we think that a TNA of 5, which is there's no available slots Monday, Tuesday, Wednesday, Thursday, or Friday, is actually a TNA of 7 because no available slots Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, or Sunday. And I'm giving you that example based on clinics hours that are closed on weekends. I hope that makes sense. I can't tell what people are thinking or questioning. And of course, as you're counting, you're looking for the third next available appointment slot, not the first next available appointment slot, because some have just canceled this afternoon, so it's not really a great reflection of true availability of our time. And so that's why we incur the third next available slot. Of the what it is, why it's important, and how to count it. I'm really happy to hear that live examples today from PCN. Leanne, are you repeating my question came in on the patient's perspective?
Yeah, out at the beginning there. So if you wouldn't mind maybe just cutting that one again.
Oh, sure.
Then we have one question if you can see that. Otherwise, I will read it aloud for the group.
No, I can't see the question, so you will have to read it aloud. But basically, the idea of the patient's perspective is that as we're counting that, the counting time, the number of days to the third slot, we always include the days, the work days, that the physician or the nurse practitioner is away. So, for example, for example, holidays or conferences or even sick time that the physician would normally be in the clinic, but they are not for whatever reason. So do include that as a day that the patient has to wait. Hopefully it makes sense.
We've got a question from Melissa. She said, from Monday to Sunday, only be 6, because first day of counting is 0.
Yeah, it kind of depends on what's your actual routine count day. So you're right. If it is the Monday that you're counting, it goes 0, 1, 2, 3, 4, 5, 6. Okay. Questions?
Anyone? Yeah. Anyone has any last quick question for Angie before we move on? Please chat it in.
I don't see any other questions. So I'd like to thank Angie for taking the time to come and speak at our webinar today. Our next presenter is going to talk to us about access, and this is Brittany Fox. She is a clinical improvement facilitator with Edmonton Southside PCN. Well, Brittany.
Hi, thanks for having me come chat. And here in a large room with the Edmonton IF network. And we are just chat today about a few we've done lately at the Edmonton Southside PCN around promoting access. Can everyone hear me okay? Yes? Thank you. Okay. So the main initiative we took this year around access promotion at our PCN was hosting a 2-part access workshop, which we collaborated with AIM to do. So we recruited 8 clinics to attend this workshop, and it's a snowstorm the day of, so 6 actually ended up attending the first session. And so we helped facilitate, and June Austin hosted. And the first session ran from 5 to 9, and it focused on really promoting the PDSA cycle to start, and then just explaining why access is important and going over some of the strategies to improve access. And the reason why PDSA was focused on so much was the doctors and clinics were encouraged to pick 1 or 2 of the strategies to improve access and then bring them back to their clinic and try them out and kind of reassess how things were by the time of our next workshop. The second workshop that we hosted, the clinics came back and we reviewed where they were at and how things went, and they also calculated their ideal panel size. Next slide, please. See that on there was some incentive for the, if a patient attended, there was some incentive for them to come to this workshop. And so just more on the first workshop, they did go over TNAs as well, talked about waiting room culture, so trying to address the idea that in order to be successful, you need to have a full waiting room of patients and that your patients should be waiting a long time for appointments. The what's in it for me, this is just a bit of a snapshot from their presentation about, they tried to address the clinical, business sides of what's in it for me, the provider and staff satisfaction, that when you can get home on time, you're more likely to be satisfied in your working environment, that patients are more satisfied with access, and then talking about aligning priorities. Please. Seeing this for these are some of the generally recommended improvement strategies. What June did in the first session was she went through each of these columns and really in detail explained each item and encouraged the people attending to check off or circle any ones that they wanted to work on. Next slide. This is just, I just wanted to briefly go over what stood out for the teams, what they decided to work on, and how that went. So one clinic, their goal was just to calculate their ideal panel size. So they went and took that information, learning how to do that, and they worked on that. Second clinic started collecting TNA. They hadn't been doing that yet. They started calculating supply, demand, activity, and cycle time. So some of these can be a bit labor intensive to calculate, so that it really takes your team on board and buy in. So they took the initiative to start trying to look at where things were actually at with their clinic. And that's still ongoing, so that's working well for them. This clinic wanted to work on, this is a single physician that wanted to work on removing all of his carve-outs at his clinic. He worked in a larger clinic. So what he found was that because of the policies at the clinic, he actually wasn't able to remove his online booking because either all of the physicians had to remove it or none of them. So wasn't able to remove his emergency slots just because of the policies they had at that clinic. And he did make some change around the day of. They would open the emergency slots for anyone. I think it was partway through the day of. So this was of a learning for us that perhaps we should really try to promote office managers coming to these sessions as well, especially with some of the larger clinics. If a physician buys in, they may not be the one that's actually managing day-to-day processes and their schedules. I think had kind of an interesting they wanted to work on a script for the receptionist around the doctor went on vacation. So this doctor had found was she had such a good long-standing relationship with her patients that when she went on vacation, they called to book and they were told they all wanted to chat with her first day back about how her vacation went and where did you go. And not only was she coming back to often a backlog of work, but she had longer appointment times because of these patient conversations. The clinic adopted a strategy where if a doctor was on vacation, the front desk staff would just say the doctor is unavailable. She reported that worked well. The other doctors at the clinic liked that idea, so they spread that change. And she also did a vacation contingency planning strategy where she blocked off the mornings, she up the week after her vacation. And the first day of the vacation, she opened the mornings of that week. And the first day back, she opened the afternoons. So she reported that was a little bit intimidating the first day back to see that she had all those afternoons open, that they actually filled up the day of and she didn't have any openings that week. They really liked that contingency planning model. The next clinic focused on removing half of their carve-outs and trying to spread the knowledge to the rest of their team. So this doctor, I think they had 2 different types of carve-outs and they just eliminated some of them. It seems to be working well. Our last clinic really tried quite a few things in their time off. They tried removing the carve-outs, non-urgent appointments later in the week and leaving the Monday visits for the urgent visits, bringing the return visit rate and trying the vacation strategy, as well actually as max packing. So just I'll share what they learned on a couple of those. The return visit rate, the doctor learned that it doesn't really work for diabetic patients very well because the insurance plan many of them are on need 3 months prescriptions, and he was trying to extend his his visits to 4 months. They talked about some strategies he could do around this, such as booking, trying a different population, continuing to reduce their visits to every 4 months, but still prescribing every 3 months. He'll adjusting this going forward. He also found max packing. It did take quite a while when trying it out, so that's trying to deal with many of a patient's issues during a visit rather than just one at a time. But he was going to continue doing that just very slowly, not all of his patients at once. So that's a bit of an overview of how these clinics did trying their PDSAs. And next slide, please. So this is kind of our own. This is just at the second workshop. They followed back and they shared all that information, and they also calculated ideal panel size. So this involved, we also reviewed the HQCA report to look at the access measures, and then they used this information to do the ideal panel size calculation themselves at the workshop. Next slide. And then sort of our own PDSA at our PCN. We found that workshop was very helpful for our clinics, but we often have more buy-in if we bring a condensed version of our workshops directly to the clinics. I wanted to try, instead of a 7-hour access workshop, trying to bring a small access presentation to a clinic. Our clinics that had attended the workshop, they asked us to present it to the other doctors that couldn't attend. So we brought out just this past Saturday, actually, a 40-minute presentation to 9 of their doctors. And because we didn't have as much time, we really wanted to give them just what mattered in a brief snapshot of access. So in the presentation, we again talked about why access is important and a bit of the what's in it for me. We talked about different ways to measure access, such as the TNA and the HQC report measures. And we went over the principles of access and the strategies to improve access. We also, while we went through the presentation, on the PowerPoint we had data that was specific to the clinic as a whole. And the doctors each received a handout that just had a snapshot of their own data. We thought that it might be more meaningful to them if, while we were going through this information, they could look down and see where things were actually at with their own patients. If you see the handout, it's not really meant to be readable, but I can just explain what's on it. So the doctors all received, we pulled from the AIM website, a 1-year TNA graph. So just showing how many days till their next available appointment, calculated each week over a 1-year period. The doctors also received from the HQCA report their return visit rate. So we used this from the HQCA report because we wanted to show them how many times their patients saw any primary care provider, a true measure of the demand that their patients actually needed appointments, rather than just how often their patients were able to get in to see them. We showed a bit of information on continuity. So we showed a continuity score to the provider and to the clinic, which we got from the HQCA report. We showed their hospital data. What we pulled from this was the emergency department usage for general practitioner sensitive conditions. So we showed the doctors what percentage of their patients had GPSC visits, and then those visits, what percentage, the graph you'll see there is just the percentages broken down by time of day. It's pretty interesting for many of the doctors to see that some of them had 70% of their GPSC conditions were happening during the day. It's a bit of an eye-opening moment to consider if your clinic is having any access issues. Just down at the bottom on the right side, you'll see we presented them a bit about ideal panel size. So we gave them the breakdown of how we calculated their ideal panel size and what numbers we used, and then gave them the comparison between their current panel and their EMR and what their ideal panel size should be. So just a bit of learnings just from the weekend. In the future, if we bring this presentation out, we probably won't actually give the ideal panel size numbers. We might give all of the information that led us to get that number, so the difference between their supply and their demand. But because our actual strategies don't usually involve promoting reducing your panel, unless that's a specific need for that provider, we don't really want them to focus on this idea that they need to lose 800 patients. We would like them to focus on other strategies they can use, like reducing their return visit rate or max packing or using their team better. We also had a bit of issues with the physicians about the suggestions around substituting face-to-face visits for other types of communication. And there are lots of really interesting ways that they could be doing this, and that their EMR allows secure patient messaging. But right now, Alberta, the compensation doesn't really line up to these strategies. So they were saying that physicians are only able for one phone call a day, and they're already doing 7 phone calls, so they'd be doing more. That's a bit hard to argue from the business side of things. Some positives that came out of this workshop, the doctors liked the idea of scripting around vacations, and that kind of resonated with them, that they also had similar issues. They liked the idea of trialing some contingency planning. It also sparked a lot of really useful discussion around while they were using their interdisciplinary team and nurse practitioner. And it was helpful to hear the different conversations between the physicians, that some were using their nurses a bit more efficiently than others. I also talked a bit about that there was a bit of disconnect with this clinic about the physician and the MOA staff. So it's a bit of conversation about how to connect better as a team, and hopefully we can use that to get some QI team actually developed here. Some providers were reviewing their day sheet with their team during the day, and some weren't. So it brings up as a strategy, seems to bring some interest in doing this with some of the other providers that haven't already been trying this out. Interestingly, by showing them their clinic TNA graph, one doctor suggested that they might decide to hire a locum over the Christmas holidays because there's such a huge spike over that with their clinic. They might try to be able to meet their patients' needs that way. So just a bit of what we've been doing here, and we're still learning, and but it's like a really interesting topic that we're trying to bring to our clinics a bit more. Yeah, answer questions.
Brittany? Leanne, is there any questions? I can't see that, sorry.
One question, Brittany. A person would like to know if you would be able to provide a copy of that last slide that you shared so that they could replicate at their clinic. And so we would be happy to put it on our Collaborate page where all these could access it.
I have just one that doesn't have any specific data, so I can send that off.
Thank you very much.
I really liked the idea that the one clinic had with vacation strategies, and the physician was unavailable at the time. I'm just wondering if after a while, how long has the clinic been doing that, and have patients started to realize the physician was on holidays, or do you think maybe at a conference or something else?
I haven't really heard other than, sorry? Sure. I haven't really heard other than that it seems to be working well, and I think what they do is they say the doctor's unavailable, she'll be next available at this date. But had a bit of...
All right, this is Erin from the Oliver Care Network, and formally with the Lynx Clinic, and they have used, they've been booking all the time process forever. It's always worked really well, but about 4 years ago, they started using a similar scripting. They had physicians who had medical issues themselves, and they were wasting a lot of time in visiting about their personal lives. So the policy at the Lynx Clinic, as far as I know, is still to just say that they're not available no matter what the reason they're away is, whether they have the day booked off for a conference or whatever. And the patients haven't had an issue with that. So I guess the policy is sort of that the reason the doctor is unavailable is not any business of the patient. The only relevant thing that they aren't available is they're next available on such and such a day. So we sort of had discretion whether they shared further.
We had one doctor that was away at a conference, and I think they had said to his patients that he was away, and his patients were all saying, "Oh, you must have really enjoyed your vacation," and he said he felt exhausted from this conference. They all thought he was away on vacation, so it seems like a good policy to try.
Great. Thanks, guys. Is there any other questions, Leanne?
No, there's not questions.
Okay. The other thought I had was, what ideas would you give to the physicians to help their current panel? So you were talking about how their ideal panel was low, and you don't really want them to start a smaller panel. But what ideas did you give to your physicians with their current panel on how to use their interdisciplinary team better?
To talk to them about how to better use their, to meet their supply and demand, we went through those team improvement strategies around, different improvement strategies around how to reduce demand and increase supply. Specifically to using their interdisciplinary team better, actually they shared a lot of their strategies. Some of the doctors shared how they were using their team. For example, one doctor said for his visits, he just sees the first visit, and then the NP manages it from there on, as long as he's in the clinic to deal with anything urgent. The NP really just takes over those patients. So some of them were sort of interested in that. Some had some questions. I also talked about if they notice they have patients coming in for a lot of mental health appointments, they do have a behavioral health consultant in that clinic, so trying to use that as a bit of a trigger to initiate staff a bit more often.
Well, thanks for sharing, guys, and I look forward to hearing how it's going in the future.
Thanks.
So, do we want to put the next one? Thanks, Dan. So we have a new strategy we want to try with everybody. And it's a new feature, and we've tried it before, and we had some issues with it, but we want to try it again. And just like improvement facilitators, we keep trying. So I don't know if everybody can put in the chat. That's where you want it, right, Leanne? Oh, sorry. No,
nope, actually, I just launched a poll.
Yeah. So is BNIF what you expected it to be? And it's a yes or no answer. So for everybody to have a few minutes to enter their answers. So closing the polling in 10 seconds.
Well, hopefully I'll be able to launch it and share the results with everyone.
Yeah. And
just down on the end here.
I think on a game show. Yeah. some results, and 18 of 38 people said yes. And I can't read. Does that need more information, Leanne?
Oh, me, I thought I hit my unmute. No, it's strictly just a yes or a no question.
Oh, and that would be 47% that I'm taking it? So yes? And 7?
Yeah.
No.
No, you're correct.
Okay. And 7 of 38, so 18% said no. So that'd be interesting to know what we were thinking. It would be. And 13 people didn't answer.
Yeah, it could have been just because the timer had run out. I used a shorter timer just because we've had issues in the past.
Yeah. Well, I get worked. We have one more poll question. And were you able to...
Here in a second. Yeah. There we go.
So what is one word to describe what being an IF means to you? Type answer here, please, on the side. This poll in 10 seconds.
Yep, another probably 10 seconds on my end to finish tallying the results.
Okay.
Apologize if anyone seems to be encountering any trouble, whether it's something froze or anything like that. If you were having problems and you tried to answer and weren't able to, if you could just chat that in, just so that we know maybe on our end what happened so that we could maybe troubleshoot it. That would be a pretty good thing. Thank you.
Trying this polling is to try and get a little bit more involvement with everybody and hope to get a little more interactive.
So I had hit poll results and apply.
Yeah.
Let's try one more time. Nothing's through there.
Can we get people to maybe type in the chat what words they put in so then we can...
Apologies that that's not launching. I do have a couple answers coming through here. So relationship, knowledge. We've got persistence, salesperson, enduring, change.
Yeah, give everybody a few more seconds. And I'm sorry that the second poll didn't work out as well as we hoped it would, but it'll be fun at least typing some stuff out.
Later.
Yeah.
Okay.
And wording?
Have one inspiring.
Okay. Okay. So that's about it now?
So that's not going to launch, so we'll just skip ahead here.
Okay. So, our next call is going to be on June 4th, and it's around facilitating quality improvement. And as you can see, we're going to finish up a little bit early today, and some of that has to do with we didn't get too many questions on the presentations, and we decided to go with a shorter agenda today. So the slide, you can join Collaborate by emailing info@pcnpmo.ca if you have not already done that, or if you're a new IF on the phone today. The subject is a place so that we can all collaborate, ask questions of your coworkers or people that you're not able to maybe communicate with on a daily basis. Include your first name, last name, email, contact phone number, which PCN clinic or organization you are with, what your role is, and what, an email back with your login information. If you're having problems with that, you can also, that info@pcnpmo.ca will get you help. Our website, so this is a section called Collaborate. This is where we will place communication with other IFs, ask questions, and share resources. There's also the discussion part of that website that you can ask questions to the group. And webinars are scheduled for the first Monday of each month, except for holidays, from 3. And like I said before, our next one will be on June the 4th. Everybody for joining us today. Hope you have a good afternoon.
Thanks.
Thank you.